Yep.
You are on.
All right. So, everyone, I'm David Jeffs. I'm an emergency medicine resident physician, meaning I graduated med school. This is my third year in training in emergency medicine specifically, and I'm actually currently applying for pediatric emergency fellowship, which will be an additional 2 years of training for a 30 to 50% reduction in salary. So, I don't know why I'm doing that, other than I really like kids. So there you are. I'm talking about pediatric seizures, but I'm happy either now or if anybody has questions later on, whenever you watch this, I'm happy to answer them. You'll see me in the department. I'm the really tall guy, like the really tall guy. So, okay, here we go. I don't have any disclosures. Like, I'm not affiliated with anybody. Be nice if I was, but so with kids, actually, a decent number of them are going to have some sort of seizure activity. 1% seems like a little bit, but I mean, the number of people you as EMS providers are overseeing, you're going to see a decent amount of seizures in kids and adults. So 3 to 4% will have the textbook febrile seizure, which is kind of between 6 months and 5 years old. It is more considered complex if they're older than 5 years. Well, I'll get into that in a bit. And then for kids, 10% of all like pediatric calls are for seizures. And then, not that this does anything, but just I'm always interested in the mechanisms behind things. Children just don't have the insulation around their nerves and their neurons like we do as adults, and that's why they're a little more susceptible to having seizures. So you'll get the common ones that are everyone thinks of when they have the seizure, where they either contract and just get all tight like they're bearing down, or other words that I probably shouldn't say here. And then they can have the clonus, or just shaking of the whole body. That's your tonic, would be the tightening of muscles, and then clonic would be the shaking. But then there's a bunch of other things that are less along those lines, where you might have like the lip smacking, the purposelessness. And if it's generalized, they're not responding to you when this is happening, then that is considered a generalized seizure, even if it's not that their whole body is shaking kind of thing. They can still have focal seizures that I'll get into, that they can sort of respond to you and still have a partial seizure. With these generalized seizures, often they'll lose their continence of bowel or bladder. They might bite their tongue. They usually will have some degree of postictal state. I think you've all have seen it. Kind of looks like they're drunk. And to some degree, they can have weird numb, tingling sensations. Also possible to have like a Todd's paralysis, where like it kind of mimics a stroke, where like one side of their body is weak, or they've got like a facial droop or something. We still have to treat that like a stroke, even in kids. But until it is more likely after a seizure to be just from the seizure itself. Okay. All right, so different seizure types. Generalized or symmetric, you've got the tonic-clonic. the atonic, which is kind of more like your drop seizure. That happens a lot more in kids. I have links in this slideshow. I don't know if those are gonna work with how we're doing this, but in the next slide, which it might, yeah, where they'll just kind of be walking around and then have like a seizure type activity where they just drop or they just kind of lose all tone in their body. The absence, or I don't know why, for some reason, when I was in med school and every medical provider uses the French accent on absence seizure, but that's how it's called. For whatever reason, the French described it. So instead of absence, it's absence seizure. Yeah, exactly. Very fancy. But that's just where they kind of, it just looks like they're staring out into space. But they might not and that might only last for like a couple seconds, but they won't remember what happened during that couple seconds. If you like move your hand in front of their face or something, they might not remember it once it's done. Then you've got myoclonic, is similar to the tonic part of the tonic-clonic. And then you've got the non-convulsive generalized, which is what really is scary, because the patient might be sitting there doing nothing and they're still having a massive seizure in their head. That's why often we have to transfer people out of here and make your lives very hard, because you end up doing transports on these people because we don't have usually a 24-hour EEG that can catch these people that are just like out of it, and you don't know if it's because of all the benzos they've gotten or are they just having a non-convulsive generalized seizure. So nobody likes a like a 5-hour round trip minimum to transport these people to Kansas City, but that's often why, is because we don't have the 24-hour EEG to catch the non-convulsive. And then your partial seizures, you've got the simple, which is like they might have like a limb flapping like this that they can't control. And sorry, people on the computer, you're not going to see it, but my arm's waving up and down like, I don't know, a bird or something. Yeah. But they're still able to talk to you, and they just can't control this. And it's really weird. Like, they are truly having a seizure, and they're doing this weird activity, and you can't. Oh, he's got the. Yes, they're talking to you, or at least crying or something, and they're doing this, and you're saying, "Oh, you're not having a seizure because you're talking to me," but that's not true. They're having a simple or partial seizure. Okay, I'm done flapping. Okay. So you can. Now, is that an emergency though? The question is, there's a difference between emergent seizure versus not. Yes, this is a true seizure, so people might not be making it up and faking it if they can talk to you while they're complaining of a seizure. So you don't just think they're a moron or trying to be drug seeking, but are the simple seizures emergencies that need to be aborted immediately with benzos? The answer is no. So they might be real, they might not be making it up, but the treatment is like an acute treatment with benzos is worse than just watching it in those cases. Okay, so I've got the video examples. I don't know. Sorry, I'm just making your life miserable today.
My shoe fell on the bottom of the chair. It's fine. It wasn't its new iPad holder.
Yeah. Okay. Yeah. So this is what a kid does with like a generalized seizure is different than your big adult. So some weird stuff, like a parent might show you this and you're like, oh, that's not a seizure. No, actually, the kid is having a seizure. So they're hard to recognize sometimes. Yeah. And like how the hands are curled and
Oh yeah.
yeah.
All curled up.
I think I've got another video or on the next slide. So tight. All right. Here's your drop seizure type example. Okay. Yeah. If you would.
Yeah. Very cool.
Yeah.
Yeah.
Not the greatest video quality. I was trying to find a good one, but yeah.
Yeah.
So yeah. Also, really, I forgot to say there are about 40 different types of seizures that kids can have. So, 40. Yeah. So some of these, like that drop seizure, probably not. You probably don't need to go lights and sirens. Honestly, probably don't need to come to the ER, but I'm not going to tell a parent not to if they're asking you as an EMS individual. But yeah.
The one that just dropped. How long was that last? Was she just stand up again in the moment?
Yeah. I think in this specific individual, the physician that kind of posted that at permission of parents said, like, this kid will often have several, like, she'll drop like that, and then she'll have a few more, like, dropping episodes, and then she'll come out of it, and they'll usually need to give whatever abortive medication. So, yeah, it's, in my mind, even like with all my extra focus on pediatrics to try to recognize these, it's scary how many different types of seizures there are. And I guess from an EMS standpoint, biggest thing is just learning the generalized that need to come in right away versus ones that, if parents are concerned, yeah, you can bring them in, but they're not needing to be like intubated or shot up full of benzos. And basically, it's kind of those generalized ones where they're not coming out of it and I'll talk about it more, but when they're not coming out of it is when you need to start doing more aggressive treatment. Okay, oh, yeah, sorry. Do you want me to do it?
Dr. Jeffs, I tell you what. No,
I think this is the last one.
You said there was 40 different types of seizures.
a chair here.
Yeah. Yeah. So it's just that one leg that's twitching. You can see the patient's fine, their head. Sounds like he is talking a little bit with that trach, or like moving his lips at least, like trying to. So yeah, that's kind of where things are. All right. So in kids, this is by far the most common cause of seizures, the febrile seizure. And this is going to be another one of those where, yeah, if a parent asks you guys to bring the kid in, like, probably not going to say no. But if it's a seizure lasting less than 15 minutes, and they've got a fever, like a known cause, like, oh, my kid's been coughing, and then a couple hours ago they spiked a fever, and then I just saw them start having a seizure. It lasted 5 minutes, but by the time you guys got here, fever or the seizure stopped. What do I do? Um, from my end of things, the answer is nothing. It's Tylenol and ibuprofen. Just keeping that fever under control, and as long as that seizure doesn't come back, it's you're good. If it's the first seizure that kid's ever had, or even the first one with this like most recent illness, yeah. The neurologists, and I've had several conversations with different pediatric neurologists because parents want justifiably some reassurance that this kid that's been shaking and not responding to them for 14 minutes is okay. So I try to get that backup to say, hey, this isn't just me. Oh, I just smacked the mic, so sorry for those listening. But yeah, this isn't me. This is like the dedicated, not just neurology, but pediatric neurology saying, we just ride the course on this. But anyway, more demographics. Yeah, if a kid has one of these, 50% of them are going to have another one. If it's not within the next 24 hours, that's still fine. You let it ride. When I get worried or say, hey, we need to investigate more, we need to get this family some medication, so if this kid has another seizure, they can stop it, is if it lasts longer than 15 minutes. And I don't know, like, I don't think I could just stand there with my 3-year-old or 6-month-old, just watch them shaking for 15 minutes. That's a hard ask on the parents, but that's what they recommend. 15 minutes, or if it happens again within the next 24 hours, or if it's shorter, recurs again, or if there's a postictal where they don't come back to normal level of consciousness, then you're getting into, I'm confusing complex with status epilepticus is when they don't return to full level of consciousness in between, which is a level up from complex seizures. And then almost 20% of these are, if they're lasting an extended period of time, are from meningitis. Yeah, I don't expect any of you to be doing LPs out in the field, though. Probably. No. Okay, so I mentioned status epilepticus. That would be any seizure lasting more than 5 minutes without return to full consciousness, or refractory between that, or don't return to full consciousness and happen to have another seizure. So if they have one that's 4 minutes and then they're walking, talking, have another one, they don't need to be slammed with stuff for status, but they might need to stay in the hospital for continued observation and monitoring. If they meet this criteria, we're going pretty heavy on the treatment. And that's true of you too. If you've got a kid that's been seizing for 3 minutes, they don't need treatment. If it's longer than 5 minutes, you can. I don't know what your protocol is. What do you guys use? Versed, like intranasal usually to start with, because yeah, I mean, I just imagine that at first, by the time you get an IV in, it's going to be definitely this long. So I don't know.
Slam them in there pretty quick.
Yeah, okay.
Slow IV getter, what do you say?
Yeah, well, I'm definitely, hey,
Massive.
all of you will be better than me at getting IVs in. I'll tell you that. Yeah. For kiddos, it's probably still good to have an IV, but if you want to try like an intranasal while you're trying to get an IV, or like a different, like Children's Mercy recently has been recommending a lot of the dissolvable clonazepam. I don't know if you, I doubt you guys have that on your trucks, but you just stick it in their mouth and like inside their cheek and it dissolves. Yeah. But even just doing that, the intranasal Versed while you're trying to get an IV in, it can kind of get them to stop shaking and make the
Active seizures and all that tonic movement.
yeah.
Intranasal is probably the best route.
Yeah.
To get control over it and then have an IV.
Yeah.
Or any subsequent.
Yeah, absolutely. Because it's hard to get lines in when somebody's shaking. Yeah. Okay. So, and then it's considered refractory if they fail 2 or more doses of the standard treatment. Again, just I kind of got distracted by what you guys use on your trucks.
Oh, okay, all right.
But that was my fault. I asked the question. I want to direct it towards you. But if they like seize and then they're postictal for 2 minutes, kind of out of it, and then start seizing again, yeah, just give them meds. If they come out of it and don't, like they're coming back to consciousness, or even if they're postictal, but like they don't have another seizure, and the first one was less than 5 minutes, according to the neurologists, they don't recommend medication at this time. So.
That would be a scenario though for us, for instance. That child probably still needs to be transported.
Yeah.
Not allowed to refuse. I mean, there's always.
Yeah, you're not allowed to refuse for sure.
There's always sticking points there with parents.
Yeah.
That kid needs to highly be encouraged. The parents need to be highly encouraged to transport that kid to the hospital.
Yeah, absolutely. If it's like if you're confident and they're just like really wondering what they should do, and you know a little bit about febrile seizures, if it's the first one, they have a clear like, hey, my kid started coughing yesterday, spiked a fever today, only was shaking for 2 minutes at best, and acting, sick still coughing, but otherwise normal, don't need to come in. But obviously you can't refuse them.
Yeah.
Yeah. But if there's any question, or if they're still acting confused, just like the one seizure, but they're still acting not themselves, then yeah, 100% should come in. And if they start having another seizure, should be medicated while they're on the way.
Like the parent or the child?
Yes. Okay. Okay, this is just saying that, so those definitions I showed you are kind of national standard definitions. I'm going to show you just one protocol that was in the textbook we use. I don't know what your specific protocol is, but in general, when somebody has a seizure, start with airway, make sure they aren't having vomit in their mouth, which is actually fairly likely. Once you, okay, if they are not currently seizing, I made this presentation a little while ago, and I'm disagreeing with how I did this. But if they are not currently seizing, or if you have another person that can get history while you're working on the kiddo, it's actually pretty important, especially if you don't have room for a parent to ride with you. Because we have these kids that come in sometimes, and we know nothing about what's going on. I don't know if they've ever had a seizure before. I don't know if they even had a seizure before they got brought in. All I know is from one of you guys, the parents told us that they saw a seizure. We weren't there to see it, and we're here now.
Yeah. This could be another neat tool for the Pulsera app.
Yeah.
Take a video of a seizure.
Oh, 100%. Yes, if you have the hands.
Oh, you mean
yeah, like
yeah, I know what you mean.
don't delay care to get it like a video if you don't have enough people there to provide care. But things like we think that they're sick. I talked about the febrile seizures, but then history of trauma. That's a big deal. I may not CT scan. I probably won't run a normal kid through a CT scan who's just had a seizure. But if the mom says, "Oh, yesterday they're playing on the monkey bars, fell off," you can 100% bet I'm worried about a brain bleed for sure on that, and that definitely changes treatment from my end. So if I know that, like just starting out, that's huge. If mom and dad think that kid got into the medicine cabinet, huge, because there's a narrow window for a lot of the toxic substances. I can do activated charcoal for about an hour after ingestion. After that, it's actually studies haven't shown to have any benefit. So if I know that they think that they ate or drank something they shouldn't have, I really want to know that right off the bat. Don't want to wait for parents to walk back into the room. Feeding problems, a lot of kids can have seizures from low sodium, things like that. And then if a kid has like developmental delay, cerebral palsy, that sort of thing, I might be a little more lenient about trying to break a seizure. Like if the family knows, hey, my child normally has like 2 seizures a day, I'm not going to try to just slam them with meds because maybe this is just worsening of something and we can give a little bit and just watch it. I don't need to intubate somebody with that kind of history as long as they're maintaining their vitals. And then changed or missed doses. There's a whole lot of different meds. That's another thing with Pulsera. Parents will not, they like never remember the names of the meds their kids are taking. And if they do, they never remember the doses. If we can get pictures of the bottles, or, I mean, ideally they get brought in, but.
We actually sometimes tell them to not bring them in because they're expensive. They get lost sometimes.
Yeah.
Yeah, there's all those things.
So, my naive self thought, the EMTs and paramedics, they just need to pick up, stabilize, and bring them to the hospital. But if you have an opportunity for this can save lives. Anyway, as far as what we're doing for status, which is what I would, if they're not meeting the definition of status, I would, meaning either greater than 5 minutes or going from seizure to seizure without a return to normal, that would be the reason to medicate. If they're having seizures and not meeting that criteria, do not medicate. But if they do, there's all sorts of different things you can use. We talked a little bit about the IV versus intranasal versus rectal, which is very effective, but nobody likes it. On this list, they did not incorporate the clonazepam or Klonopin, but the seizure breaking dose of clonazepam is much higher than just kind of like the maintenance dose for people. So I've seen it's up to 0.1 milligrams per kilogram. So like a 20 kid, you can put a 2 milligram tablet in their mouth, and usually they're like adults will have maybe 1 milligram, often like 0.5 or 0.25 or less. So for maintenance stuff. And parents do have those pills now. So it's good to know, like, have they had this today? Or like what, anyway. And then what do we do if we give whatever, midazolam, Ativan, intranasal and IV, and they're still seizing? Do you have a protocol for like if they're still seizing in that case?
Not a written protocol. It would be
Call.
online medical control against console because you just don't have we have a limited number of
Yeah.
meds that we can carry.
Yeah, understood.
So I don't really know what.
Okay. I for what I don't know if this was I think this was an air ambulance that had started them on phenytoin in addition to midazolam, and like this kid had 10 milligrams of midazolam and like 4 of Ativan, and we're still seizing. They got him on propofol, intubated, and had like in the chopper had phospheniton on board. So, but that's a little more probably advanced than what's in the trucks. But I bring this up because in kids I'm a little more leery of just going straight to propofol and intubate than I used to be. When I was an intern, I think like a couple months after I gave this lecture 2 years ago, we had a 1-year-old kid who was in status, had been seizing to some degree for like 20 minutes. But all that kid had been given was multiple doses of, 15 minutes and then like 5 minutes while we were taking care of him. Had like the home doses of whatever it was, I can't remember, but it was some benzo intranasal and wasn't working. So we gave 2 rounds of Ativan and still wasn't working, and went just straight to propofol intubation. And this 1-year-old kid who had been seizing, as soon as the seizure broke with the propofol, just crashed. He Brady'd down and coded. And whether that's because of the medication, the sedating meds, or the fact that we got the tube in, or maybe it was unavoidable. But I mean, I was doing compressions on the kid. I had done the initial intubation, which was great, not to pat myself on the shoulder or anything. But as soon as we started compressions, of course, the tube comes out because like your target zone in a 1-year-old is tiny. And there were a couple other issues because an adult vial of epi had been drawn, and so the kid got something that was not the recommended dose of epi. And ultimately, we stabilized him and sent him to Children's Mercy. But in a kid who's seizing, I am much more likely to try like this recommendation from our textbook that's like our Bible goes first and second line are 2 different benzos, then add on a third medication that's kind of general anti-epileptic, add a different one, and then fourth line is intubation. And so I'm don't know if things would have been different on that kid if we had tried some of the other stuff before going straight to the tube, but maybe. So that's why I'm a little bit. That's probably beyond the scope of here, but it is a harrowing story. And anyway, a lot of these medications, especially the phenytoin, not so much the Keppra, the levetiracetam, but definitely the phenobarbital, little to some extent valproic acid, will have some side effects like rash, Stevens-Johnson syndrome. So you might also get a call for a kid who is on anti-epileptic medication and their skin's just sloughing off. That can be a legit medical emergency. And it can get very scary. And we sometimes have to send them to burn centers, and they're there for many months because of it. It's rare, but very well documented situation that I have seen before. And then, of course, you know what benzos do. Okay. Yeah, so one of the things I had thought of, like in that situation, who we gave tons of the benzos to, and then started propofol, and he started coding. What would have happened if I had just kept him on either a non-rebreather or maybe a CPAP or BiPAP and let him ride the course through that medication? Would he still have coded? So just something to think about if you've got a kid that's true status and you're just not controlling the seizure. You can still give them what they need to abort the seizure. And if you are the experts in, just crazy situations, don't have all the equipment there that you need, it's easier to keep somebody on BiPAP in the hospital where somebody's there to be able to make the switch right away. So I understand, like, if you feel like you need to intubate. But worth keeping in mind that might try something else while they're writing the medication to see if they can do that. Okay. And then another big cause of seizures, and just like anything, is hypoglycemia. So I don't know why when I did this I put that like near the end of my lecture, but I'm sorry. Yeah, and you can give D25, especially in little. What do you use? Is it mostly D10 now? Okay. Yeah. If they're febrile, you can. I doubt you stock Tylenol on the trucks. Yeah. So you're going to want to do other things to cool them down. Yeah. And then we give them the Keppra usually, even if they're not seizing and they've got any sort of like head injury, we'll still give them Keppra. Got a couple that in the department right now, not kids, but a couple people with skull fractures that are going to be on Keppra for a while. They never had seizures, but there's good risk that they will. Respiratory depression. Yeah, I don't know. But like I said, the other issue with kids with intubation is that trachea is very short. So the tube is very much more likely to come back out than it would be in an adult that you intubated. So that's another reason why I'm a little less aggressive with intubation when it comes to seizures in kids now, is if you can keep them oxygenated with whatever device you have that can just be strapped on their face, that's awesome, because that's gonna not get dislodged nearly as easily. Well, anyway. Okay. So I don't know why I called this handoff, but parents will want to know kind of the risks, and I tell them that it's likely, if this is a simple febrile seizure, they're got a 70% chance of happening again. If it's like the first one, there's still, we don't recommend any treatment, just watch. Same with unprovoked seizures. The biggest thing that I want anyone to communicate, I try to talk to family about this. I want anybody else to talk to family. They need multiple reminders. If they should not be driving. They should not be swimming, taking baths alone. They should not be like near cliffs or like hiking where they could, if they had a seizure, fall off an edge. You want to take like the locks off their doors, so if something happens, you can just get right in. I know it's not your position to offer like final advice, but this is something that I don't see nearly enough compliance in parents or adults, and it's sketchy. So if I could have other people helping reinforce this, that's awesome. And then as the kid grows, their dosing is probably going to need to increase if they have a true like epileptic condition. Yeah, unfortunately, so these stats don't apply to just simple febrile seizures, but other causes of seizures, they will still continue potentially to have poor control for the rest of their lives. It can be related with learning disabilities, psychiatric people. I mean, in America, it's even harder because we don't have like public transport or things. So these people who can't do things on their own, or at least shouldn't, there's no other option. And it sucks. Any questions?
Let's ask them. They're about, 20 seconds behind us on a slight delay for the stream.
Somewhere, we just, we're, it might be a little bit longer than that.
Drags down some of the afternoon.
Interesting.
Just now switched over to discussion questions. Somewhere around there. Thank you.
Awesome. Yeah, I'm sorry I'm not like the amazing energetic guy that Jamal is. Like, you get that guy around and he's more coffee than coffee is. But anyway. Yeah.
No. Why you want to eat? Okay. Let's give the online audience a little more time to ask questions. You good with that? Yeah.
Everyone saying thank you.
Awesome. Y'all are amazing. This is kind of a very much like thankless job, or at least not as many thanks as you deserve. Pay is not what it should be for what you all do, for sure. And I just want to let you know that I appreciate you a lot. We all appreciate you when you come in.
Perfect. We'll sign out and sign back in about 3 o'clock with our next is airway management.
Yep.